people are still engaged. Yesterday, there was a really engaging discussion about relationships and continuity. And so we were kind of looking at each other from across the room here and thinking, I don't know, we'll see. So I'm hoping we saw some energy on the topic, because we had a lot of good conversation on this already. But the question is, what is continuity? What does it mean? What's the role? Why should we care? Why do we care? Or should we care? There's a lot of questions there. So last September, I came to Dallas, and I talked about measuring continuity. And what I was sharing there, for those who weren't there, I showed these slides. Basically, we have continuity data, and when you take rating of usual provider of continuity, so using the standard, are you the doctor, are you the provider, did you see your patient? That's the simple ratio that SALT's defined along with Dr. Lochner. And when you look at that measure across provider rating of practice, you could pick any measure. We picked every measure we had in our informatics system. So we have lots of measures because we measure quality or proxies of quality, depending on how you think about measures of quality in EHRs. And basically what we saw were scatter plots. So the reason I did that is because I've heard from the doctors, oh my gosh, I can't see my patients. I'm too busy. You can't give me a new patient. I have to see my existing patients, because if I don't see my existing patients, they're going to be unhappy, and their satisfaction scores are going to go down. And if I don't see my patients, they're not going to get as good control of their diabetes, or they're not going to have as good of care for their chronic disease, because that continuity makes a difference in their care. Haven't you read the Saltz and Lochner article? They didn't say that, but I'll add that. So I said, okay, let's see what kind of data we have. And I didn't find that correlation that they were saying was there. So I'm like, that was interesting. So so then they would say, the bigger my panel size, I don't know what the right panel size is, but if I have too big of a panel, my patients can't see me. Right? You've heard this kind of stuff. It happens all the time. Well, I looked at it, and I was able to demonstrate that, forget the line there, that's an automatic line. That's a random scatter plot. Okay? So yeah, for some people with the bigger panels, so if you're 1.6 times the median benchmark panel size, some people have really poor continuity, and some people have really good continuity. So there's different quadrants. But there wasn't a pattern. So I couldn't validate any of the things they were telling me. Yet my organization's saying, oh my gosh, we got to do this, and my people in my department are pushing back, saying, no, but you can't do that because. And I looked at the data, and I couldn't validate their argument. So I was wondering, okay, what's going on here? Because, we've had this discussion, okay? Relationships matter. Continuity matters. Trust matters. But who does it matter for? In what context? In what situation? That was kind of what we talked about last time. So where does it matter? We kind of talked about some things, chronic diseases. We talked about this yesterday a little bit. Maybe treatment plan adherence. We can all anecdotally talk about our patients who we have a relationship, and they come back to you and say, thank you for talking to me about that. Because it was you, and because you had that talk with me, I quit smoking. And it was because I've been seeing you for years and years and years that I believed you, and you inspired me. We all have had those experiences. So maybe that is profound, and that matters. There was an article, and we'll talk about, we can share this a little bit, on Medicaid patients with a different definition of continuity that does show decrease in cost for Medicaid patients for ER visits. But maybe not if convenience trumps. everything. So, Anoop, your generation, convenience, I'll just see whoever so I can get it done, right? So maybe for acute care, maybe the younger, healthier cohort of population. And where's population management and continuity? I just showed you our measures. We haven't published this data, but we aren't showing a profound difference or benefit on continuity on what you would argue you would measure for population health. So, and someone else had these slides too. So, okay, are we changing with our healthcare world? So the CEO of CVS Health has been known to say, we're going to change healthcare for chronic disease. We have access points, brick and mortar, within 80%, within a couple miles of 80% of the U.S. population. We're in all 50 states. We have Aetna. We can do this better than the existing system, and we're going to be disruptive. And the way they're going to do it is not with physicians in primary care. They're going to do this with lower cost APCs and yoga classes and dietitians and other ancillary services and online services. That's what they're going to say. But we can do it cheaper. And they're not talking about continuity in this model. It's just convenience, whoever it is. And then, of course, we've talked about Amazon, Berkshire Hathaway. So,
Sure. So, we've talked a little bit about the role that we think primary care and family medicine plays in improving healthcare outcomes at a population level, and a recent study that Alan shared around concentration and numbers of primary care physicians per population improving health. I don't think we really know what it is about what we do that creates that benefit or that value for our patients. I think we think it probably is continuity and relationships and trust, but I don't know if that's true. And I wonder a little bit if the future of where we're headed in terms of access trumping continuity, if that will continue to be true, if the benefit and improvements that primary care brings to our population will continue, if that's the model. I don't know if that is the model that's going to carry the day or trump continuity in the long run. The millennials, as we've said, by and large, are not folks with chronic diseases, so we don't yet know what that might look like. But that's one of the things that I sort of ponder when I think about continuity and the way that things may be headed. What even is continuity? Is it simply just the data points that you know about a person because you've interacted with them before? That's certainly an important thing that might be replicable with other systems beyond continuity, things like the IT we have been talking about. Do we think it's more this interpersonal relationship, and is it more the patient trusting the physician, or is there something from the physician point of view where we feel a greater sense of responsibility towards this person and it motivates us to do that extra phone call or take that extra step or show up in the hospital when they're sick? I don't know if we really know this, but these are some of the kind of ideas I'm putting out for your input and conversation today. And then we've talked a little bit about what is it that does generate that trust. Can you generate trust with a person who you don't see as often or you have shorter visits? And I feel this to some extent in my practice. I do more phone and MyChart interactions. Does that generate trust with people? I mean, I think in some cases it certainly can. The patient who comes to my mind is a woman who I met for the first time who wasn't feeling well. We got labs. Her blood sugar was 400. So I called her that night and we had a conversation, and she was kind of shocked that I called her at 6 p.m. on a Tuesday and that we would take that time. But just after that one visit and that one phone call, we had built a trusting, personal relationship. And even though the next few times she came to the clinic didn't happen to be days that I was there, she definitely still viewed me as her physician. So I think there's a lot of opportunity to think about how we define and measure continuity in a world where maybe more of our interactions are not going to be face-to-face. And how might this look and how might we measure it? If we think continuity is a quality metric that's maybe more important than A1C or blood pressure, we better be measuring it correctly or accurately. So those are my ideas. And we really want to open it up for your ideas in response to some of these kind of situations and questions.
So thanks for presenting this. In fact, it's better today than it would have been yesterday because we've been informed by lots of other things like, can you have continuity with a team or practice or the company, and can you have the same outcomes? I'm informed by two things watching over time. One was asthma with continuity visits or home visits, and then video visits. And the outcome of that was, if it becomes all video visits, you lose some benefit from adherence to the treatment plan. So, but you don't need as many office visits, and the total cost of care of service delivery using the different delivery channels was actually better with a hybrid. Now the right dose, not quite sure. The other thing that I think I really learned from is when managed care companies started to use care managers using telephonic outreach. And it didn't work very effectively, but when they import a care manager from a managed care company into the practice, and when they call on the phone, they say, hey, I'm from Dr. Motley's practice, and he asked me to give you a call because your hemoglobin A1C is kind of high, and just wanted to chat about that and what we might be able to do. They frame that completely differently and a little more engagement. So I think there are, it has to do with the delivery, it has to do with how we define continuities from the provider standpoint. I've even more from, I own all my patients and they're mine, and I had to give way to saying, and I've been imprinted with that. That's how I was trained. One doctor, one patient. And I'm now working in a place where there's still a couple of vestigial senior folks who that's their paradigm. And so I think we need to change the paradigm. And how do we do that intentionally, both on the provider side, and then how do we communicate that to the patient, so that while you're meeting your patient for the first time, hey, I'm Dr. And I have this great team that works with me, and I want you to be comfortable if I'm out here. Do we script that? As I've started to do that, I feel like it's being more effective, but I'm not sure if we're being effective about how we use interpersonal communication and our scripting, particularly for new patients in the panel.
Yeah, I think the team-based care is interested because we all are talking about transitioning, and many of us already do a lot of team-based care, but I don't know if we know if people can feel that bond of trust with the team in the same way that they would with an individual. I mean, we hope that, and maybe we think that, but I don't know if we know that.
I think it's an interesting idea to look at what continuity might be a proxy measure for. Because I guess it is timely in having this follow some of the other lectures, particularly because the evidence-based one, that you might not be able to find evidence that a continuity helps, that seeing the same person over and over, but it's what my patients want. And so it would be interesting to know why that is, but they want. So I've been in my clinic for 23 years. And I have lots of partners. I think the next closest to me is 15, but most people are there 5 years or less. And so my patients keep wanting to come see me. And I have lots of really smart doctors that probably are better than me at many, many, many things in medicine. And yet, the patients will want to come back and see me. And their patients, when they meet me, if I'm covering, now want to see me. So I don't know what it is. I mean, I think it's listening skills, and I think there's a lot of things like that. But it would be interesting to know what that is. And what do we do about it, even if it doesn't lead to better outcomes, if it's what people want? I agree, the talk yesterday, I think somebody talked about healthy people don't necessarily want that. But someone with diabetes or someone with high blood pressure, or coronary artery disease, or Alzheimer's, they want to have that good doctor.
I want to challenge that question a little bit. because, and maybe someone in this room will know, but has there been a study looking at asking the patients, anecdotally I've seen that as well, but have we asked the patients, what percentage of the patients actually say that? Now, the patients we see say that to us, but that's a biased viewpoint. So has there been a study that maybe, and I'm not aware of one, but there might be.
I'm not saying that because they do say it to me, but I'm actually saying it because they say it to my partners. You know, my young partners, when they admit my patients to the hospital, I'll roll their eyes and go, oh, God, you know, Smith patient, they're going to not be happy with anything I do. And I do nothing but talk good about my partners. I'm like, oh, great, you saw.
I'm agreeing with you. I'm just saying that's the cohort that have expressed that. What we don't know is what the bigger picture is.
Yeah, so I was reviewing consumer surveys for a talk last week on what do patients want, and continuity, I think, was fifth. I think that convenience was number one, and I think cost is going from 3 to 2. Of course, this is, you know, one survey, but also the segment matters. So older patients tend to rate continuity higher.
I'm beginning to believe that continuity with the system that sends a consistent message to our patients is more important than the continuity with an individual provider. And let me give you an example of where I think we fail in the name of continuity. And that's a patient that's not on my panel that I see for an acute visit, which I may or may not do as much as I could for that individual because they're not on my panel. And we see, because there's not a consistency of priorities for the system, I think we sometimes use continuity as an excuse to not provide the optimal care that we could for every patient that sees us wherever they see us. An example is our express care that we started now about 6 years ago. It was kind of an add-on. So yeah, they need acute care, so we'll just throw that out there and patients will access them. What we realized is that it was also an opportunity to get after some of these chronic diseases that we want to manage. We did a study on the control of asthma in our population. In the express care, we're involved in the management of our patients that we're seeing in express care. Our numbers skyrocketed because they were seeing them for the acute visits, but also could deal with the chronic nature of asthma. So it sounds kind of bad, right, to say that, well, as a family physician, continuity is not that important. But I think we're challenged to really challenge that notion and how best to do it. So I really appreciate this work.
So one of the things that strikes me, both to speak to that, I don't know if it's continuity to an organization necessarily though, but I don't think it's continuity to an individual. Like, I don't know that it matters that I personally see every one of my patients, but there's something in between, some structure, I suspect, in between. I don't know if it's my clinic or a smaller team, and that's what I feel like we need to define. Because I've seen places where people have a close relationship with specific APPs, specific team members, different constructs where it feels like continuity even though there's different people involved in different steps. And I think finding that structure where we can take care of the right people within that team continuity relationship for the right problems is important. The other thing that struck me a little bit is what Jeff was saying about there's something about his interaction that patients maybe say, they want to see you now. And I feel like one thing that I've struggled with a little bit is a change in the expectations of what it is to be a family doctor among my generation of doctors. And I don't know if this connects at all with this or if this is going to simply be an empty rant, but it strikes me that people are more engaged now in clocking in and out at set times. And actually, I remember one of my mentors saying the focus is how quickly we can get our patient back out of the clinic, not what are we doing for that patient. And so as we are chipping away at our scope of practice, I wonder if that relates to how these relationships between us and our patients develop, because we're not as involved in these different facets of their care. Now, I'm on the verge of a rant, so I'm going to stop with that.
I think we're talking about a lot of different things, because on the other end of the spectrum, I'm thinking about psychologists or therapists and transference and countertransference, and I think that's part of family medicine sometimes with some patients. So I think the word continuity is problematic. I mean, it can be just a measure like you could say that, X% of visits to one provider is continuity, but I think we're talking about a whole lot of different things here.
I'd like to second what Matt said, and that is our concept of team, at least my concept of team, has always been the people that I work with elbow to elbow. And it's much more concentric. It looks like a archery target. And it's great when they hit the center of the team. But the team is the gastroenterologist, the team is the OBGYN, the team is everybody else. And I think one of the challenges that those of us who work in large systems have is how do we give a consistent message and support each other around something as controversial as nutrition or the way we manage diabetes. And in my organization, if they see Wanda, they're going to get a different, probably a little bit different. If they see Jim, it'll be a little bit different. If they see the endocrinologist, it's going to be dramatically different. So I think the challenge that we have is we are part of a very big healthcare team that are taking care of a complex set of patients who are accessing care predominantly because of convenience and when they want to come. And that's the challenge.
I love being a family physician, and I'm thinking about David's talk and wondering if this is our physiology, this is our concept of how it should work. People want continuity, so we kind of, we grow around that. And I kind of think, I wonder if it's not what we want them to want. A lot of that's what I think is true. Now, there's some patients, of course, who say, I want to see you, I want you, but we really, really need that. As family doctors, we really, really want that. We value that tremendously. I just kind of wonder if patients really value that as much as we want them to value that. And is our concept right about continuity? Is it really all that critical? And it seems like maybe some evidence is that it isn't.
So two quick concepts. If you look at the direct primary care movement, you study it closely, you will find that one of the major challenges that the DPC practices have is attracting a panel of patients so that they can be successful financially. There is a segment of patients who value what we traditionally think about in terms of continuity, and they will pay out of pocket over and above their insurance. So they may have Medicare that covers everything, they may have Medicaid, but they value that and they recognize for themselves, appreciate what it can do for them, and they will pay out of pocket for that service. But most DPC practices during the first 6 months to a year struggle to get to their break-even place so that they can be viable. So they really have to hustle to find the people in the larger population who get that. Only 40% of people who are employed, when self-insured employers look at their companies, only 40% of their employees recognize the value of having a primary care physician. The other 60% do not. So that's a piece of the struggle. But the other piece, Kurt Stange did a really lovely study some years ago where he looked at the number of problems in people who were dealt with during an office encounter when the physician knew the patient. And it's something that's not reflected at all in the coding system, but the family physicians were able to deliver more care, better care to mom, dad, the kids, because there was continuity in that relationship. So I think this is just a broad area that's a lot of fun to play in.
Yeah, I'm kind of echo what was said on the other side of the room. I'm wondering how much of this plays into physician satisfaction, sense of purpose, burnout, and some of those things. Some of us enjoy being a family doctor. We don't like being an urgent care doctor. We don't like have a lot of things that are happening. And if we could segment ourselves and just have our patient panel of patients who appreciate what a family physician brings to the table. I think it's almost that, like, we have younger colleagues who like that urgent care, type of, treat them and treat them, volume, punch in, punch out. Those of us who are trained in a different model, we spend 3 or 4 hours going through our in baskets at the end of the day, because it's like a drug. We need that connectivity with our patients. That gives us our sense of purpose.
There are studies that support that. We just have a few references at the end that we'll post if people are interested in having just a very brief kind of summary of some literature, but Saltz's article, Finding and Measuring Continuity, kind of talks through a lot of these issues and just very briefly summarizes how many studies there are that show physician satisfaction, how many show patient satisfaction, how many show, quality improvements. There's a wide, and cost. There's so many different outcomes you can look at related to continuity.
Last year, I think in one of these meetings, I asked the question, are patients buying what we're selling them?
So I just want to comment. So what you said is very similar to what Mike said about, my sense in talking to the physicians when I have these discussions is they like the continuity. That's why, and I reflect, why did I become a family physician? Because when I like delivering babies, but if I were an OBGYN, then my relationship is done at that point, after the delivery, other than the 6-week postpartum visit. And I wanted to keep that relationship going. So that continuity is inherent to what drives people to think about family medicine as a specialty. That's real, and so when I have those conversations, it becomes very meaningful. That's why they say, but I want that continuity.
Struck by 2 things. It may not be one system fits all. You have different patients at different points in life may need different things, and I think there is a large part of it, particularly when they have chronic illnesses or they have a severe acute problem, want that continuity. And then there's others that it's really important the brand. I mean, it may not be their physician, but they need to have trust in that brand or in the pilot. And it makes me think of, in terms of, you asked about data, we worked with Mark Murray as a consultant when we went to Advanced Access, where you could see your primary care doctor within a day or 2. And so we did see those acute problems. And his data has pretty clearly shown that, at least with the subset that we thought we were dealing with, 1/3 of them will make another appointment to see you if they see someone else, just to verify, do you agree with what they were told? Mm-hmm. And when we got to Advanced Access, we were all able to open our panels and have larger panels because we were seeing our patients and we weren't seeing 1/3 more visits because they were coming back to verify. I hear the data on the millennials, and that may be where we need as organizations to have express care clinics that are part of our groups, because those are the high octane fee-for-service visits, and those are the insurances that cover our bottom line. And so that may be that you need 2 models. And as someone who hires a lot of doctors, a lot want to do the continuity, but some actually want to do the same day. So leveraging where you need what is what I'm taking from this.
I just completed my annual compliance, and Mercy reminded me 3 times in it that they are Mercy's patients, not my patients. However, when I get on to Epic, whose name is at the top of those charts, and so, the biggest area of need in my community is we lost a lot of physicians. And patients want to establish with me because you're the doctor, I don't want to see the nurse practitioner. Now, when they do, if I tell them, okay, that the next time you come, you're going to see my nurse practitioner, and the next time with me, they understand that. And that helps them to be very good. We had a partner leave 2 years ago, and we haven't been able to transition all of those patients. And now they go, no, I want to stay with a nurse practitioner, which our system says nurse practitioners can't be the primary care provider. But there's a lot of working parts. There's the ego of us, the physicians. We want our patients to be our patients. And then there's the system saying, you're responsible for the gap closure on your patients. So we're getting mixed signals from everybody. We're getting mixed signals from the payers. We're going to grade you, not the health system. So there's not a unifying answer to the problem that we're talking about here.
Yeah, we're grappling with that just past few months at UW Health. What does it mean to manage your panel? And that gets a little bit to panel size, but it kind of came out of a panel size question, and then it led to more of the, well, what does it really mean to be somebody's doctor and manage a panel? You know, does it mean that you see your patients more than X percentage of time? So I mean, continuity came up as a big metric potentially when it means that you're managing your panel, you're available to see them. I mean, our bare minimum is like 50% of the time. That sounds so low. But for some of our part-time doctors, that's kind of how it works. And then when you factor in the team-based care and some of the visits are with nurse practitioners and PAs, that's kind of where we're at for a lot of people. You know, does it mean closing all the care gaps, holding people responsible? Yeah, we don't really have too many answers yet, but it's a good question, I think, in this world of empanelment. What does it really mean to be somebody's doctor in this world?
Okay, great.